Okay, so I'm going to start off by introducing myself. So my name is Natasha. I'm 18 years old and I have juvenile idiopathic arthritis, and I was diagnosed at the age of 13, and today I will be the facilitator for this group. Just a little bit of background. I have a podcast that I co-host weekly with my friend Trish, and it's about rheumatic diseases, and we educate and raise awareness, but also talk about normal teenage things that goes on in our lives when we have rheumatic diseases and how we handle it. So it's definitely a great resource for other kids that want to listen to us talk. We're kind of starting up a website, but I'll put the YouTube video channel in the chat so you guys can feel free to watch it in your own time. And we covered tons of different topics, and we're trying to make it a resource for other kids just to have it because we've always felt alone. So having this resource is like a great thing for other kids. Also in Cassie and Friends, I am a tag leader. So we host events for kids with rheumatic diseases, and I'm the tag leader for Toronto. So I'll also put that link in the chat as well. So if any of your kids want to come to our events, they can feel free to do that and sign up. So before we start, I see everyone's kind of introducing themselves in the chat, and that's great. So now I'm going to start introducing Dr. Marinka Twilt. So Dr. Marinka Twilt is a pediatric rheumatologist and is trained in the Netherlands and Toronto. So after working in the UK and Denmark, she joined the Alberta's Children's Hospital in 2016, where she runs the autoinflammatory disease clinics. Dr. Twilt's interests are in precision medicine, which is really cool, for rheumatic diseases, autoinflammatory diseases, and TMJ arthritis. Dr. Twilt is active in the Childhood Arthritis Rheumatology Research Alliance autoinflammatory group and leads development in the CARA AIDS registry. Dr. Twilt is also interested in training new young generation and is active in the Canadian Child Health Clinician Scientist Program. So welcome, Dr. Twilt. We're really excited to have you today, and maybe you can start off by sharing your screen and then we can get started. For everyone here, just make sure to note that you can turn your cameras on. Just make sure your mic is muted, but thank you.
Thank you so much for the kind invitation, Natasha. I did send somebody to you because they're apparently landed up in the periodic fever group, but they want to be in the vasculitis group with Dr. Cabral. So maybe you can help the McFadden family to go to the right group. She will message you in the chat. I asked her to message you directly.
Okay, perfect. Thank you.
Let me start sharing my screen to see if that works, because you never know. And then hopefully if we do this, you should see the whole full screen. Perfect. So it's a great honor sort of like to do this talk. It's not the easiest talk. I'm sure Lori knew that when she asked me, and that's why she's sitting here listening to me instead of presenting it herself, as she could have really well done that, as she's also one of the autoinflammatory experts in Canada. So what I decided to do is sort of like to go through some of the features that most or some of the periodic fever syndromes have, and just walk a little bit like, why do we ask these questions when you come to clinic, and why is it so important for us to ask those questions to you, because you know what can we do with those answers of those questions. So the first one, which I think is probably very known to everybody, is fever pattern. Like, you know, when you come, we usually always ask, like, so are there fevers? And if there are fevers, how long have they been there? And what do we do with that? And before I go on, I will say, if you have any questions, put them in the chat, and I'm happy for Natasha to interrupt me during the presentation, because sometimes it's easier when we're talking about a certain topic to have the question than to do it in the end. So feel free to either unmute yourself and ask the question, or put it in the chat and ask Natasha to ask the question. So the fever pattern is really important for us. And why is that? Because sometimes the fever pattern can actually tell us what kind of disease it is. So we always ask usually, what is the duration of the fever? So is it 1 day, 2 days, 4 days, or longer? And that helps us differentiate already a little bit, because if you look at the different periodic fever syndromes, or they're now called autoinflammatory diseases, and the reason that they're called that way is actually because not everybody has a fever. And that's why they change from periodic fever syndromes to autoinflammatory diseases, because there are kids that have periodic fever syndrome without fevers. So the duration of fever is really important because sometimes just with you telling me how long the fever is, I could potentially already tell you what kind of diagnosis I still have in my head and which ones I can already discard because it really doesn't fit with what you're telling me. The other thing is it a high or low grade fever? So there's always also difference in the different diseases. Do you really have like, you know, a 41 degrees fever with these episodes? Or are they around 38 degrees and not that high? So that's really important for us as well. And also, is there any reaction to Tylenol and Advil? Like, you know, do you get the fever down? And if you get the fever down, does it go completely down to normal? Or is it more like, well, from 41, it goes to 39, but they're still quite miserable with the medication? So that's really important for us all to know. And that's why we ask these questions. Another question that is really important from us, and that's why usually I think most people ask you to keep a diary, because we really want to know sort of like what is the interval between episodes, when does it happen, and that also again really helps us with like what kind of fever syndrome is it. I'm sure there's a couple of PFAPA parents on the call, and you know that you can almost predict when the next fever is going to happen. You can say like, oh, I can look at the calendar, and if they had the fever on the 1st of July, they always have it every 4 weeks. So I know the next fever will be the 29th of July. And I can sort of like, unfortunately, put my social calendar on hold that week because I know that there's going to be a fever. So the other thing is like, you know, some fevers are variable. They just happen once in a while. Sometimes it's influenced by cold as well in some of the periodic fever syndromes. So some patients actually get a fever after they have been exposed to cold, and it goes away again after a couple of hours. Let me see now, because now got myself stuck here. The interval between episodes, is there days between the episode? Is it weeks between? Is it months sometimes between episodes? And as I said, is it clockwise, which is really what some PFAPA patients have. They really are like every month, every 3 weeks, every 6 weeks, and you know exactly when the fever is coming. So these are really important questions for us to ask. And then the question that I always get when I have a new patient in clinic is like blood work. You know, what blood work can help us differentiate if this is an autoinflammatory disease from another disease? And it can't really help us really say definite this is an autoinflammatory disease or this is an autoimmune disease, or but it can help in a way. And most of the time it is that it can help if you do blood work during an episode and if you do blood work after an episode, because without any medication you should have really high inflammatory markers, or at least raised inflammatory markers when you have an episode, which should go completely back to normal when you have no episodes. And in some of the fever syndromes they're different. So some of them have really high inflammatory markers, and some of the, again, PFAPA parents will know the CRP goes up really high, and that's why you usually get antibiotics prescribed or more tests done, because people are really afraid that you have an infection, because these are also inflammatory markers that go up if you have a cold or a pneumonia or a urinary tract infection. The ESR is usually a little later, so that's usually not as high in the beginning and lags behind a little bit. There's also some of the periodic fever syndromes, if you think about TRAPS or CAPS, those inflammatory markers don't go up that much. And it's sometimes even more difficult then, because then you really have to look at the little nuances that are there during an episode. It's just a little higher than it should be, and not in an episode it is completely normal, but it's not as pronounced as in some of the other periodic fever syndromes. But it can help us. But as I said, it doesn't differentiate between the different periodic fever syndromes, and it also doesn't differentiate with any other inflammatory disease. White blood cells is usually what we also look at, because they usually also go up during one of these fever episodes. So usually you get a complete blood count done as well at the same time. And then there is this serum amyloid, which in some centers you can, and some centers cannot have access to. But serum amyloid, it's also just a little protein that floats around in the bloodstream, but it can potentially be up in certain periodic fever syndromes. It will be up in everybody who has an inflammatory process going on. So if you have an infection or if you have something, it will be up. But in some autoinflammatory diseases, it doesn't settle if you're not having an episode. So in between episode, it doesn't go down. And that's where it should go down, and if you have a continuously raised amyloid, that could give you potentially risk that this little protein would settle down in kidneys or in other organs, and that potentially would give long-lasting damage. This does not happen in all the autoinflammatory diseases, and we do know a little bit in which autoinflammatory diseases we could potentially expect it and in which ones not. PFAPA, for instance, has no serum amyloid risk, so we would also not, at least I would also not then measure it, because then there's no use of measuring it. But for instance, in familial Mediterranean fever, it is known that amyloid can be potentially raised with certain mutations. Urinalysis is usually also what we want, because we also want to know if the kidneys are working well and if the amyloid potentially couldn't have been damaged before we see you, and also just to know if the kidneys are not losing any proteins. Skin rashes. It's not the best picture, I'm assuming, behind your computer, but there's many different skin rashes that can appear in the different autoinflammatory diseases. And again, they can help us with differentiate between the different diseases. So there are certain diseases like CAPS, which have an urticarial rash, which is very distinct, that you don't see in PFAPA or you see in familial Mediterranean fever. So the skin helps us a little bit as well with what we can do. So although this is not a really good photo, it is usually very good to take pictures if there are rashes associated with episodes, just because it helps us, or sometimes to dermatology if we ask them to help us as well, to really see if they can differentiate between the different rashes and maybe help us differentiate also what kind of autoinflammatory disease it is. As I said, urticarial rash is associated to one specific group of autoinflammatory diseases. Then you have a rash that is very even painful and swollen, that looks like it could actually be infected, and that's cellulitis-like rashes. And a lot of kids are actually treated for cellulitis, which would be like a skin infection, before they are sort of like diagnosed with an autoinflammatory disease. So these are things that can lead us towards a diagnosis. And then there's these like more descriptive, if you ask the dermatologists, they say maculopapular, but they're just rashes that are red, bumpy, and they appear. And that's why it's so good to make pictures, because it's really hard to describe rashes if you're not at that moment seeing it, because everybody describes it a little bit different. And then some of them are cold induced. So some patients will get just only a rash when they're in the cold, which if you're like me in Calgary at this moment where there is a cold spell, that would be very unfortunate, and might actually mean that you might have to move to Hawaii maybe too, where it's a little warmer if you could. Then another thing that can be involved is joints and muscles. And this is just a picture to show like a normal joint and an arthritis joint, but it's not always arthritis that actually happens with these diseases. A lot of kids actually suffer from joint pain, or sometimes even more muscle pain. There's also joint swelling, sometimes arthritis in some of the autoinflammatory diseases. But the muscle pain is probably the one that sort of like stretch all the different autoinflammatory diseases. And also in PFAPA, we see more and more that kids are really complaining about leg pain when they have their episodes. So there is like some inflammatory process that the muscles are going through as well. And then of course, if you have bone pain, the CRMOs, which I haven't really touched on yet, but chronic recurrent multifocal osteomyelitis, which is a whole mouthful, but it means you have a chronic inflammation in a bone which is not caused by infection, and sometimes they have it on in multiple bones. That can give bone pain as well, and sometimes the bone pain is the only thing that actually would lead to a diagnosis, because usually these kids don't always have anything else except pain in a bone, usually in either an arm or a leg. Then the head and neck, and this is specifically for patients with PFAPA, where some of the PFAPAs are coming from in the PFAPA acronym, and that is tonsillitis. Some kids really have severe tonsillitis during their episodes. Lymph node swelling, where in PFAPA it's mostly in the cervical area, but in some of the other autoinflammatory diseases, you can also have lymph node swelling more over the whole body, so in the groin area or under the armpits. And of course, oral ulcers is a big feature in a PFAPA or in Behçet's disease, which is sort of an autoinflammatory disease. and swelling around the eye. So we call that orbital edema, but that's actually in TRAPS, one of the other diseases, really a feature. And then genetic testing. That is always a big question. Like, should we do genetic testing? When do we do genetic testing? How much genetic testing do you do? And there are specific genes identified for different autoinflammatory diseases. We do have to remember, though, that probably the oldest known periodic fever syndrome or autoinflammatory disease is called familial Mediterranean fever, and has been described in more the Mediterranean area for a very long time, years and years. But the gene was not found until 1997. So these are all relatively new diseases, because that means any of the other diseases are actually found after 1997. And now still almost every year there's a new disease that comes out in this spectrum of autoinflammatory disorders. So it's a relatively new disease, and it's not like lupus and JDM and JIA where we know a lot already about it. We have to learn a lot in a short period, and we're still finding out new things. So we find out that there's actually symptoms associated to certain genes that we haven't thought about before, and that we thought was a different disease that turned out to be actually caused at least by the same gene. Genetic testing is not recommended for PFAPA, and specifically in Canada, there's this choosing wisely how to choose your lab work as a physician consciously. And genetic testing is actually not recommended for PFAPA, just because there is no genetic gene known at this moment. And it probably is one of those diseases where you have to have multiple little mistakes in your DNA, which we all have. If I sit here, I have multiple mistakes in my DNA. Everybody has. It just depends where you have your mistake, if you would have any physical symptoms from that or not. Then if you have a genetic mutation, it always is it inherited? So is it because mom has one certain gene, dad has one certain gene? If one of the children gets both, they have the disease because they have two of the genes? Or is it because it just appeared in the child itself or in the patient itself, and nobody in the family has it? That's called de novo, so it's new in that family. The broader your test is, also the more you find, and you might think that is positive, but it isn't always positive, because, as I said, we all have mistakes in our DNA, and we call those variants of unknown significance. And it means that the broader you test, the more of those variants you find, and you actually don't know what they mean, and it becomes sometimes very difficult, and sometimes it also sort of like almost takes you away from going any further or thinking in a different direction. So it's not always good to do broader than you should. And it should be really guided by your physician or healthcare provider and a geneticist to see how far do you go, how many people need to be tested, and do you have to do testing in your family if you would find something in one of the children. So I wanted to go quickly a little bit in a specific periodic fever syndrome so that you know a little bit about the most common, although as Dr. Tucker already said in the first talk, there are no real common periodic fever syndromes. PFAPA is probably the most common one because we see it the most. But if you think about TRAPS or CAPS, they are really like 1 in a million diseases. So it's not like we can call these common periodic fever syndromes. So PFAPA, most parents of PFAPA patients would know, but for other parents, PFAPA stands for periodic fever, adenitis, pharyngitis, and aphthous ulcers. And that sort of like tells you what a complete PFAPA patient would look like. They have periodic fevers, they're high, so they're usually around 40 to 41 degrees. They usually last 3 to 6 days, so sometimes it's a whole week of fevers. They usually have lymph nodes, and that means that they don't really want to move their neck. They have the tonsillitis, which is the pharyngitis, and then they have the oral ulcerations. And these children's really, as I said, fever every 3 to 6 weeks. It's almost clockwise. You look on your calendar, you can predict when the next episodes will be. Duration of the fever is 3 to 5 days usually. They can have pain in their throat, pain in their mouth, pain in their neck, and leg pain. And in the beginning, when we started to notice this, a lot of patients who had just fever or who had just fever and tonsillitis were all captured under this PFAPA, but probably there are different patient populations under this as well. And then the most probably a great part of it is they're completely well in between episodes. They're completely normal kids in between, and they grow and they have no long-term effects of their fever syndrome. The attacks usually stop by late childhood. As I said, there's no genetic mutation identified. There are high inflammatory markers during attacks, and usually these children have been seen by physicians, providers for a long time. They usually have lots of throat swabs in the system if you look at it, because there was always a question, is this an infection or not? And then the treatment of PFAPA, because there really isn't any long-term effects, is really quality of life. And it's sometimes not even quality of life specifically for the patient who suffers of PFAPA. It's sometimes quality of life for the whole family, because you can imagine if there's 6 days of fever every 3 weeks, that is very impactful for the family. And now in the pandemic, we're working from home sometimes, but then still, you know, it's really impactful to have a child home for 6 days of fever, and when can you go back to school again? So the treatment is like, how well can you treat your child with which medication? So, and that some parents say, if I give them Tylenol and Advil, they're actually very comfortable. And if that's what it is, then I think that's a great way to go through the episode, but not a lot of patients have enough on just NSAID. Then one of the treatments there is prednisone, which is really great because you give it on day 1 and sometimes still day 2 of the episode, and it should abort the episode. There's a little caveat there that sometimes the frequency between the interval becomes a little less. So instead of every 3 weeks, they could have every 2 weeks an episode. Tonsillectomy seems to help. I do have to say that there are very sort of like on both spectrums you hear it. So some people say completely cured. Usually that is if there's a lot of tonsil involvement, but there are also patients that went for a tonsillectomy who just had fever and were completely cured. There's also, unfortunately, a lot of patients that still have fevers after the tonsillectomy. Sometimes it helps to have lower fevers and not that high. Sometimes it also helps that the episode is not as long, so they don't take 6 days anymore, but potentially 3 days after surgery. And then you could give a treatment that is called colchicine, which is a tablet that is taken twice a day, 1 to twice a day for a long time, for every day. And FMF, so that's the other sort of like common autoinflammatory disease. So it stands for familial Mediterranean fever. As I said, this is sort of like the one that we know the most about. Episodes are every couple of weeks, but sometimes months. It's not really as regulated as PFAPA. You can't really put a clock on it. Episodes duration is much less, so usually it's only 1 to 3 days. Most patients have abdominal pain, so they complain about severe abdominal pain, sometimes chest pain and joint pain. And this one has a genetic mutation. So there is a mutation in a certain gene, which is called the MAFV gene. And this treatment is colchicine in the first line. And if that doesn't help, there are other treatments. But luckily for approximately 90% of patients, colchicine is a fantastic treatment. And then this one does go with like a risk of amyloidosis with certain gene abnormalities. So not every patient with FMF has an increased risk on amyloidosis. And the amyloidosis risk is really if it's untreated. So even in countries as like Israel and Turkey, where you have high FMF populations, they luckily don't see secondary amyloidosis that much anymore. One of the rarer diseases, and I won't go through all of the diseases because, as I told you, it's a spectrum that has gone really broad. So there's like so many diseases at this moment. If I have to discuss all of them that are so rare, where maybe there's also nobody on the call, then we could sit here for another day or two, and I don't think that's what we want to do. So I have TRAPS and CAPS, where we quickly will walk through. So TRAPS stands for tumor necrosis factor receptor associated periodic syndrome. And this is one of those that the episodes could be every couple of weeks, every couple of months, but some even have just 1 episode a year. So this is a very different kind of periodic syndrome. Duration of episodes is 1 to 4 weeks, so it's a long sometimes, and it can be very impactful. And sometimes it only stops for a little while, and then potentially 4 weeks of symptoms come back again. So it can be very impactful. So a lot of abdominal involvement, or at least gastrointestinal involvement. Usually painful skin rashes are associated as well, muscle pain. This is where the periorbital swelling comes up as well. And this treatment is a little different because this really depends on the frequency of the attack. So you can imagine if your child only has one attack a year, don't really want to give a medication every day or continuously if there's only one episode a year. So then you just treat the episode. But you can also imagine if you are continuously having these episodes, you really want to have a medication that could potentially at least hopefully dampen, if not completely resolve the symptoms. And that is really with biologics. And this is like anakinra, which is a daily medication, or canakinumab, which is much nicer because it's only every 8 weeks. So then CAPS, the other one that I will quickly go over, is called cryopyrin-associated periodic syndrome, although I have to say that they're now going to NLRP3-associated periodic disease, which has to do with the fact that that is the gene, NLRP3. And we also have noticed that it's not good to call something a disease, and CAPS is officially divided in 3 different diseases, which is familial cold-associated syndrome, FCAS, Muckle-Wells syndrome, and then SINCA or NOMIC, because that depends on which side of the ocean you live, if it's the UK or North America, what you call it. But we found out that it's not 3 diseases, it's just a whole spectrum of diseases, and people have symptoms of a little bit of Muckle-Wells and SINCA, or a little bit of FCAS and Muckle-Wells. So it's better to call it like one disease instead of like arbitrarily putting it in boxes where it actually doesn't belong, because that sometimes can cause problems. So these episodes, again, they vary between days, weeks, months, or continuous. The duration of episodes can be 1 to 3 days, but it can also be continuous and the severe spectrum. Urticarial rashes, joint pain, and this one is in the severe spectrum associated with hearing loss. So some of you will probably be asked to do a hearing test when you come, and we haven't really been able to say yet what kind of autoinflammatory disease you have. We usually ask you to do a hearing test just to make sure that, because it's the hearing loss that we won't notice in the beginning, but it will be later on. And then the treatment depends on the spectrum, because if you have the familial cold-associated syndrome, that's the people that have all the cold-induced symptoms. So if they're walking from the sun into an air-conditioned mall, they actually get into trouble because it's all of a sudden so cold for them, and then they get a fever and they feel unwell. So you're only treating them when they have the symptoms, where if you are a patient who has the other end of the spectrum, where there is, like, for instance, a risk of central neural hearing loss or arthritis, then of course we treat continuously just to make sure that you don't have any of those long-lasting symptoms. So this is a little bit in a birth fly over autoinflammatory diseases, because it's too short to say more. So I think, as I said, much more is needed as new diseases are identified every year. We have new spectrum of known diseases, as I said. So there's a lot of diseases that we've known, but we now find out that there's also this spectrum instead of like that one phenotype of that one clinical picture that we identified. And also new treatment pathways are identified, which is great. So there are sometimes that we find that there are new possibilities, because we find that there are new pathways identified at that moment.